Welcome, and thank you for joining this webinar on the active prevention and treatment of maternal sepsis, a multi-component intervention to improve maternal infection outcomes. This webinar is organized jointly by the World Health Organization, the UN Human Reproduction Programme, HRP, and the University of Liverpool. My name is Dr. Mercedes Bonet, and I work at WHO in issues related to maternal infections and sepsis at headquarters in Geneva. I'll be moderating today's webinar, and I'm looking forward to hearing from our speakers groundbreaking results of the implementation of the APT-Sepsis program, and also from our colleagues in Malawi and Uganda, where the trial was implemented, on how the program was implemented in the trial sites and its implications for health workers and policymakers. Would like now to welcome Dr. Pascale Aloti. She's director of the HRP and the Department of Sexual, Reproductive, Maternal, Child, Adolescent Health and Aging at WHO Geneva for the opening remarks. Please, Pascale, over to you.
Great. Thank you very much, Mercedes. Good afternoon, colleagues and partners. Thank you for joining us for this webinar on preventing and managing maternal sepsis as we present the new results from the APT-Sepsis trial. This work was led by WHO, HRP, and the University of Liverpool, and it could not be more timely. Maternal sepsis is an emergency hiding in plain sight. It is one of the fastest progressing and most lethal maternal complications, and yet it is almost entirely preventable. Each year, more than 18,000 women die from maternal sepsis, and over 12 million more experience severe illness, disability, or long-term consequences. These are not abstract numbers. They reflect gaps in basic infection prevention, hygiene, clinical vigilance, and timely response. And they contribute directly to the global stagnation and even reversal of progress in maternal mortality. And the urgency is clear. We're off track to meet the SDG goals, 3.1 specifically, and no country can afford to lose women to infections that we know how to prevent and treat. So against this backdrop, the APT-Sepsis trial offers compelling evidence that change is possible even in highly constrained settings. Across 59 hospitals in Malawi and Uganda, involving more than 430,000 women, a structured, sustained approach to maternal infection prevention and management reduced severe infections and infection-related deaths by more than 30% compared with usual care. A 30% reduction achieved not through new technology, but through systematic implementation of what already works. The intervention strengthened core practices, consistent hand hygiene, appropriate antibiotic prophylaxis, reliable monitoring of vital signs, and early structured response using the FAST-M bundle. These are foundational actions, and yet when applied with discipline and accountability, they save lives. This trial reinforces a simple truth. Maternal sepsis is not inevitable. It is a symptom of health system failure, and it is reversible. So today, as we share the findings, we also underline a call to action that every health system must prioritize infection prevention and control, clinical readiness, and the routine application of evidence-based guidance. The tools exist, the evidence is clear, and what remains is the collective will to ensure no woman dies from preventable infection. Thank you for being a part of this effort, and I look forward to the discussion this afternoon. Thanks. Back to you, Mercedes.
Thanks, Pascale. Let's turn now to our speakers. I would like to welcome Professor David Lissauer from the University of Liverpool and the Malawi-Liverpool Wellcome Research Program in Malawi. for the first session of this webinar. Professor Lissauer led the work of the APT-Sepsis trial and will be presenting main findings of the study.
Thank you, Mercedes, and thank you, Pascal, for the compelling remarks. It's a huge privilege to be here on behalf of the whole APT-Sepsis team to present the active prevention and treatment of maternal sepsis trial, a multi-component intervention to improve maternal infection outcomes. And we really wanted to start and felt it was important and fitting for the opening slide to be a survivor of maternal sepsis from Malawi, telling us her story and the devastating impact that maternal sepsis had on her.
Unfortunately, never got sick in maternal sepsis. 19 one of operation. Ulina nitapita kubafa na ndibazona ndikusa mazi ina sister wanga nanzozona kuti maziwo autokera babala kena bwana kaida na a doctor nabwera atabwera atandiona anango ndikonzapo ndizozona kuti ndikile doctor ukula akabwera atabwa kuzandiona doctor ja anango zozona kuti kuzokhala kuti chibereko yanga chikuonongeka kena bwana ndoma ndipasa antibiotics anandi masa kwamasuku angapo kena kusukuna nazabwera zanduzo zonena kuti mene zili ndikena kuti tipite kufiyeta manoti kapita kufiyeta awenena kuti akachotse chibereko changa chifuna kuti chimaonongeka ndineso kuthandiza zozona kuti sinizakhaso ni mwana kuti pamene mwana amene sunali naye anamwalira Nazi zokwenda kwa basi manali bekisa kujina ndinalo la kuita kufida bana ntsasibeleko mara vendo kwa ngene senza belegaso ayo kufida kucha anakanisa kwa ICU arona zona kuti condition yanga ikusinta ananditenga no kundipitisa ward ngabwera daily manisi mulisuka bala chakuti likhali mweva ina kwana titusa ndinkangoendera masika nasikona kuti ndinachira ndinge.
Thanks. I mean, we really appreciate her sharing her story, and I think for many working in hospitals around the world, that will be an all too familiar situation that she describes. And we all recognize far too many women dying each year from this preventable problem. And it's not only the women dying, but as we heard, the devastating consequences for the woman, for her baby, for families and whole communities, and lifelong consequences. Next slide, please, Mercedes. We had the benefit of the WHO GLOSS study that really examined the problem in health facilities around the world, not only demonstrating the scale of the problem, but importantly highlighting that even when women died from other causes, infection was often an underlying or contributory cause, in fact, to just over a half of all deaths in hospital. Next slide, please. And we recognize that this is a complex problem with an interacting number of upstream deficiencies and challenges, with low adherence to hand hygiene, issues with how antibiotics are used, delays in recognizing infection and deterioration, and providers working in very restrained healthcare settings with challenges of healthcare staffing, overcrowding of facilities, and stockouts of key resources. So this is really where the APT-Sepsis intervention was born, developed over years with a lot of stakeholders, different formative studies to optimize it, where we really wanted to support healthcare workers working in these challenging environments support them to change behaviours and achieve the 3 goals of the APT-Sepsis programme. Next slide, please. And to highlight these 3 goals, the first goal was hand hygiene, so adhering to the 5 moments of hand hygiene and using correct technique. The second goal was to improve infection prevention and treatment, so making sure that we used antibiotics correctly, so antibiotic prophylaxis used according to WHO recommendations and best evidence, not used when it isn't required, and that infections were treated with the correct antibiotic regimes. We also aim to improve safe surgical practices, avoiding harmful practices, and ensuring we wash the skin and vagina correctly with antiseptic prior to caesarean section. Goal 3 was sepsis detection and management. So detecting sepsis early with a structured observation chart and ensuring routine observations were taken of women. And then when sepsis was suspected, using the FAST M sepsis bundle, of which we'll speak more in a moment. So there's not the opportunity to talk in detail about all aspects of the intervention, but we'll share a QR code at the end that links to all the resources and details, and they're also available in the supplementary of the paper. But just to highlight in goal 1, working to get hand hygiene at every moment, we adapted the WHO 5 moments so that it was suitable for a maternity setting, and worked with providers, for example, using a low-cost UV light box training session to get our technique right, whether we're washing our hands or using an alcohol-based hand rub, and thinking about appropriate glove use. For goal 2, using antibiotic prophylaxis correctly. This included being supported by tools such as the gestation wheel that included advice on the right antibiotics to use for specific infections, and posters. And then at caesarean section, not only the right antibiotic prophylaxis, but preparing the abdomen and the vagina according to WHO guidelines. And this again was supported by practical sessions, doing this with whole teams, and also posters and other materials. Goal 3, suspect sepsis, start FAST-M. So early sepsis detection, the use of a structured MEOWS early warning chart, ensuring that all women who were inpatients get their observations taken routinely, recorded on a structured chart that triggers escalation when required. And for women with suspected sepsis, so red flags and suspected infection, the FAST-M bundle is implemented and completed within 1 hour. This is fluids, antibiotics, source identification and control, transfer if required, and monitoring of the mother and, if appropriate, the baby. Really key to this was the implementation approach that supported healthcare workers to change their behaviours. And this was designed to be an implementation approach that was practical, appropriate to the context, low cost and scalable, working within existing health system requirements. So the implementation strategies were hospital leadership engagement, so onboarding the facilities, including engaging their leadership, absolutely key, and we'll hear more about these later, were the project champions. So these were facility staff selected from diverse roles, and all the key locations within the facility. These were not champions who were paid extra, but who worked to support the implementation of the program. Implementation tools, so simple paper-based tools like the observation charts, the fast end decision and treatment checklist, memory aids like I've mentioned, like the posters, a pocket reference guide you could take away from training, and the antibiotic guideline gestation wheel, and then soap and alcohol-based hand rub were provided if required. Multi-professional training and mentorship. So we used a champion-centered train the trainers approach. So the champions were trained, they then went out to the hospital sites, co-delivered training with the central hub team. This was 2 days of training delivered on 2 occasions, so the whole facility could benefit from it. And then the champions carried on leading and providing ongoing mentorship, coaching, onboarding staff members when there was turnover. This training and mentorship was supported by manuals, flip charts, presentations, videos, and the practical sessions. And then finally, dashboards and feedback. So the hub team visited the sites on a quarterly basis, providing supportive review. And there were dashboards available so that sites could see how they were performing. Next slide, please. So what did the trial ask? The trial asked, does implementation of this APT-Sepsis program in health facilities reduce infection-related maternal mortality and severe morbidity? The design was a 2-arm parallel cluster design with baseline control phase. So what that meant is all the sites started in the baseline phase, had at least 6 months of baseline. Half the sites then entered intervention, half continued with their usual care. There was a 3-month transition period to allow sites to be onboarded, the intervention to embed, and then up to a total of 12 months where the intervention was then continued at those sites. In addition to the main trial that we'll discuss the findings from today, there's a separate mixed methods process evaluation to explore how the implementation operated in reality across the intervention and usual care sites, and also a cost effectiveness evaluation that will be reported. The unit of randomization was the health facility. Those were the clusters. And these were secondary level health facilities delivering comprehensive obstetric care, so able to do cesarean sections and blood transfusions, and delivering at least 1,500 women per facility per year. Because of the number of facilities, you can see from these maps in Malawi and Uganda that the facilities were spread throughout Malawi and again broadly across Uganda. These included government and also non-governmental facilities such as mission hospitals. Next slide, please. The intervention group received the APT-Sepsis program as I've described, and the control group continued with usual care with passive guideline dissemination. But now the study's ended, all the control sites have had the opportunity to also participate in receiving the APT-Sepsis intervention. I'll focus on the study primary outcome, which was a composite outcome of infection-related maternal mortality and severe morbidity during pregnancy, childbirth, or within 42 days of pregnancy ending. And so this composite included infection-related maternal mortality, infection-related maternal near miss, so when a woman nearly died but survived, and also severe infection-related morbidity, and this was deep wound infections, deep perineal infections or body cavity infections, peritonitis, endomyometritis, and these were really carefully and robustly defined, and these outcomes were collected every day by study project officers. There were also a range of key secondary outcomes, both maternal and neonatal, collected, and some implementation outcomes that we'll also discuss. Thanks. In terms of the study flow, just to highlight there were 59 health facilities in the end that underwent randomization. 30 were assigned to the intervention group and 29 to the usual care group. And this was really an enormous trial and undertaking, with 430,000 women overall delivering in these facilities during the trial. So, on to the results. And as we've already heard from Pascal, we were really excited to be able to find at the end of this huge undertaking and report on the key primary outcome of the study. And that demonstrated a 32% reduction in our composite primary outcome of maternal infection-related mortality or severe morbidity. So just to explore that a little bit more, what we found is that in the intervention phase, the usual care clusters, the primary outcome occurred in 1.9% of live births, whereas in the intervention clusters, it was 1.4%. What one can see when one examines this graph, which shows the three different phases of the study: on the left, the baseline pre-randomization phase; in the middle, the transition phase; and on the right, the post-randomization intervention phase, is that the blue and red lines, blue being usual care, red being in the intervention in the baseline phase, overlie each other. The transition phase is grayed out. This data wasn't used in the analysis. And then after the transition phase, one sees a clear separation of those clusters in the usual care and in the intervention, with the intervention clusters having a significantly lower risk of this primary outcome. In the top right of this figure, we can see the risk ratio as it changes month by month during the duration of the trial. And what one can see is that this improvement in the intervention clusters is sustained for the duration of the trial, and if anything, getting better as the trial progressed in the last month, around a halving of the primary outcome. There were some key pre-specified subgroups, in particular examining the effect in Malawi and Uganda. And in Malawi and Uganda, we can see that there was different baseline rates of the primary outcome, with the rates being higher in our sites in Uganda than in Malawi. But really remarkably, the actual reduction that we found between the intervention and the control clusters was exactly the same in both countries, with an identical risk ratio. We also were very interested with this range of facilities that were involved, whether facility size was going to be critical in how the intervention worked. And again, we can report here that facility size did not seem to be particularly an important factor, and that the intervention worked across facilities, be they small, medium, or large, which we found really reassuring. We have broken down the primary outcome into its three component parts, and one can see that the reduction in the primary outcome was very much driven by the most dominant and common factor, which was severe infection-related morbidity. Mortality was, fortunately still uncommon, so those numbers are small, and infection-related near miss, though the effect sizes in the direction we would expect favouring the intervention, again, those numbers are much smaller. So severe infection-related morbidity was what was driving our effect. Next slide, please. We had a range of other secondary outcomes. I think just to highlight that some of the risk ratios are a bit counterintuitive if you look at the raw numbers, and that's because the risk ratio isn't only looking at the intervention phase, but is also taking account of the model includes the baseline phase. So it's a slightly more complicated calculation than just looking at these numbers to determine the risk ratio. But for all of these other secondary outcomes, we only saw a small reduction in the risk that wasn't significant, with the confidence intervals crossing 0. In terms of implementation outcomes, we had implementation outcomes that were focused on each of the goals of the intervention, and these were consistent with our findings that we had successful implementation across each of these goals. We just need to remember that the implementation outcomes were done by direct observation. This was an unblinded study, so there's some risks of bias in that. And also to note that we saw improvements across each of these implementation outcomes, but there was still incomplete implementation. So there's still space for improvement. We saw a doubling of hand hygiene compliance, but still it was at 33% in the intervention site. So we could have pushed things up even higher, and similarly across the boards. So interesting to see these very large reductions and to think what could be achievable even with additional resources to further support healthcare workers as they work to reach these goals. Next slide. So in conclusion, really fantastic to report that implementing the APT-Sepsis intervention reduced by 1/3 maternal infection-related mortality and severe morbidity, and that this effect was consistent across countries, facility size, and sustained for the duration of the intervention. We feel this has really important implications. It was a programmatic solution, carefully developed to work in a low-resource setting. It's low cost, sustainable, and we hope ready for scale. Thank you very much. Here's the QR code just linking to the website, as I mentioned, and also you can find this link in the paper so you can access all the resources and find out more about the study.
Thank you, David. And now it's my pleasure to introduce our second session. This is the Voices from the Ground session, where we will share more about how the APT-Sepsis program was implemented during the trial, both in Malawi and Uganda. So we have with us today Professor Catriona Wade. She's from the Infectious Diseases Institute, Makerere University in Uganda, and the University of Liverpool, and she was the principal investigator of the APT-Sepsis trial in Uganda. We have Regina McLooney from Malawi Liverpool Wellcome Research Program and the APT-Sepsis trial manager for Malawi, and Peace Owaro from the Infectious Diseases Institute, Makerere University. She was the APT-Sepsis trial manager for Uganda. Over to you.
Thank you very much. So, as we've already heard, maternal sepsis is a very devastating condition, and behind every one of those numbers is a family and a community and even a wider society who have been impacted by the positive results of this trial. But as David was presenting the results, perhaps you were wondering, how did we actually do this on the ground? And one of the most striking things to see across both Uganda and Malawi was that even before we had the results of the trial, we almost knew that there was going to be a positive result, because we would go onto the wards and we would hear stories of how that ward used to be overflowing with sepsis cases, and now there were only 2 or 3 patients remaining. And we would hear stories of sites where they used to have antibiotic stockouts, but now the antibiotic use was going down so much that they weren't having those problems. So I will hand over to Peace to start taking us through some of the practical experiences from the ground.
Yes, thank you very much. Thank you, Katriana. I'll just dive into the implementation of APT-Sepsis. This is for Uganda and Malawi. So we started with onboarding the sites, and for the intervention, we had to work with the champions. So we had the site preparations, champion identification, and also the training of champions. Then also followed up by the facility trainings. These were on-site and they were champion-led trainings. Then also the champion support that came through, it was ongoing. They had to continue with mentorships, coaching that were happening in the different departments, mainly obs-gyn. Then the monitoring aspect and the support supervision from the hub team, this had to happen quarterly together with the Ministry of Health, and also the feedback from the dashboards was really important for the champions and the sites. Next slide. Yes, so as I already said, the champions were key levers for this. So we really would like to thank the champions that worked across all sites, both Uganda and Malawi, because the trainings, the mentorships, the coaching that were happening were really fueled by them. Then also they had to ensure availability of the supplies, vital monitoring equipment in the wards to ensure that the vital signs are being done, and also to build and foster teamwork among staff. If you look at the different components we had, you can't actually implement them alone. So they had to actually ensure that there is teamwork among the staff, and also documenting all the activities. They had diaries, so they were able to document all the activities, the trainings and the mentorships that they were conducting, and also sharing the experiences with other champions internally and other participating sites. So this was across board, both Uganda and Malawi. Next slide. Yes, so on our goal number 1, which was hand hygiene at every moment, looking at the training that we had with the champions using the hand hygiene ultraviolet germ gel, this was powerful for the champions, realizing that you can actually wash your hands, and after some time you realize you haven't washed them well because you haven't followed the steps of hand washing or hand rubbing. So this was key, using that light for them to be able to see. And also in terms of ensuring availability of soap and water. And for the sites that didn't actually have hand washing stations, the sinks, they had to improvise the movable ones for the different points that needed to have. Then we also had to have the alcohol-based hand rub at all times. So the champions were really fueling this. And for the posters, if you look at the pictures, the posters, I think during implementation, having the customized posters for maternity care units, these were really key for the midwives and the obstetricians working in the maternity care area. Next slide. So still on our goal number 1, you can see the progress after the training, where we had, this was in Malawi, but we had the hand washing station, the bucket, the one for water and the one where the water would go in. And by the time they went for the quarterly visit, they had actually progressed and was looking much better. So availability of the posters, hand hygiene audits within the department using an app, and also ownership of the intervention. This we saw across all the sites, and the support staff involvement in terms of ensuring that these are refilled in a timely manner. Next slide. Yes, so on goal number 2, our goal number 2 was mainly on the vaginal preparation and antibiotic prophylaxis and the correct use of antibiotics for treatment. So what we saw here for vaginal preparation, multitasking was a key here to ensure that this is done in theatre and for all the mothers. So you could have all the mothers at least in theatre by the time we're stopping data collection. vaginal preparation was being done. And starting from the training, for them to embrace the training, you can see the picture there during the training. It was a hands-on training for the champions. And they went ahead and actually developed their low-cost model. If you look at the pictures, this is what from one of the sites, to be able to coach, mentor, and train other new staff and students on ward. Then on prophylaxis, to ensure that this is given in a timely manner, most of the sites embraced this practice and ended up even changing their patient flow, where you would have antibiotics given in theatre, mainly to achieve the timing, the 15 to 60 minutes. Next slide. So still on goal number 2, and we had reminders, quite a lot of reminders from the champions to their fellow champions and also the staff. And in terms of improving documentation, because this was the key bit, even the practice when it's done and it's not documented. So they had to develop different tools. One was creating a column in the theatre register so that they're able to document that it's being done, and also to run quality improvement projects on antibiotic prophylaxis and vaginal preparation. So this was done for most of the sites. And if you can look at the pictures there, you're able to see where it was included in the checklist for prophylactic IV antibiotics, the time it's given, and vaginal preparation in theatre. So different sites developed different tools to be able to monitor this. Then adaptation of the preoperative checklist and the support from the hospital supply chain to ensure that sites had iodine or chlorhexidine in place, and the antibiotics for prophylaxis. Next slide. Yes, so for the next slide, Regina is coming in, the coordinator Malawi.
Hi, everyone. Thank you, Bess. Hi, everyone. So I'll continue with goal number 3 on suspect sepsis start first AM. So just like Bess has explained, there were a number of approaches that were adopted from different sites. For instance, the pre-attachment of the observation charts in the patient files. So this served as a reminder to say every woman has been admitted, pregnant or after delivery or after an abortion, was supposed to be monitored using the chart, which went on really well. And also documentation of the vital signs and responding to any deviation, because this vital sign monitoring chart is not developed only for the sepsis, but also they were able to flag some complications that are arising from different issues in the maternity, for instance, postpartum hemorrhage. And also the duration of the first term treatment band with the patient chart. So what we observed when we're doing our quarter review is that as time goes, champions and all the staff in the maternity, they got used to the first term tool that we used. So as a result, they will even just use their patient monitoring files to document the first term treatment band that the patient has received. Next, please. Yes, and reminders also helped. These reminders were actually being done by the champions. They had spot checks. Some of the champions, some of the they developed their spot check kind of loader, whereby they were visiting each and every department to monitor how these tools are being used and then continuing their mentorship. And also recognizing best practice within their facilities, so that motivated other healthcare workers to continue using the charts to monitor and also to manage this maternal sepsis. The reminders that came in from the APT-Sepsis Central team also helped a lot in terms of keeping the momentum at the facilities to be able to use to achieve the goal number 3 when they're identifying sepsis and also manage. Next. Yes, I want to talk a little bit about the performance dashboard that we saw it as part of the game changer in the implementation of APT-Sepsis. So we had different dashboards that were developed centrally by the APT-Sepsis team. These dashboards were real time. We used dashboard 1 for monitoring the availability of infection prevention control resources. So this was really helpful because we would tell, remember our data was being collected on a daily basis by the project officer. So we would tell that such facility is running short of, for instance, the gloves or maybe fluids, which was not really common. But then we could respond right away and facilitated that all our sites. We tried and we managed to have enough resources throughout our intervention period. And also it helped us in rapid gap identification, which I've highlighted, and also performance tracking. So during our quarterly visits, we soon after the quarterly visit observations, we had this dashboard that were given to the champions and to the facility staff to appreciate how they function, how they performed during that quarterly visit. And that was like a center for the discussion, because they would clearly see, as you can see on the picture, this is for one facility, quarter one up to quarter three. So you could see how they were performing. For instance, on the hand hygiene, 7% compliance on quarter one, and then they moved to 75%, because whenever they visual actually see their performance on a dashboard like this, it helped them a lot to perform more. So these dashboards, apart from we were actually giving out as posters. So every month we could send each facility their poster indicating how they're performing in different goals, and that also helped them to monitor their quality improvement projects that they had in different goals of APT-Sepsis. So it really served as an important feedback to win as far as implementation is concerned. And it also facilitated data-driven action, because you could see managers from the facility, the moment they've seen the dashboard, they could create a number of actions that were driven by the data that was shown through the dashboard. So the dashboard really saved us a lot in terms of a very important feedback too. Next. Yeah, finally, I would like to acknowledge the team that has supported a lot in terms of our implementation of APT-Sepsis, starting from the Ministry of Health team and also the APT-Sepsis core study team. We were working very hand in hand, because as you can see, it was a lot of work for us to do the quarter reviews and the trainings, but the team from the MIS supported us a lot throughout the intervention period. And also, even when they visit the site to do other things beyond APT-Sepsis, they could also just check on how sites are doing in terms of the implementation of APT-Sepsis. Our champions and hospital managers, who has been very key in the implementation, and also the ward teams, because we needed the ward team to implement this. So they've really, we would like to acknowledge them a lot. And the project officers, who were midwives and clinicians from all our implementation facilities, including the control sites, they were collecting data on daily basis, Monday to Sunday. So they've done a good job for us to have these results today. And last but not least, the district health management teams, who were on top of things to support us whenever we're doing our quarterly visits, the trainings and everything related in the districts. Yeah, and just like Malawi, for Uganda as well, the Commission of Reproductive and Child Health and MOH, different Ministry of Health officials and HUB team members, and even the team from the facilities, they've done a good job. As you can see, the moment we finalized, we completed our data correction, in all the countries, we had a celebration to celebrate the end of data correction, because it was really a huge work, which was indeed very important for us to do, because for us to have these results today, it was due to the comprehensive data collection that we did in all our facilities. Thank you.
Thank you, Catriona, Regina, and Peace. It was great to hear more details about the app program implementation and details on how this was done during the trial. Before closing the webinar, I would like to invite Associate Professor Luis Garama from Kamuzu University Health of Science and Principal Investigator of the APT-Sepsis trial in Malawi to share his reflections. Over to you, Luis.
All right, no, thank you, Mercedes, and thank you for all the presenters. My role is to wrap up what APT-Sepsis or this intervention has been. But one of the key things I believe for us to be where we are sharing the successes of the trial, first things we did was just to make sure that the process of engagement was done in the right way. So we initially started engaging the policy makers within the ministry before we went over to the facilities. So we did sell the idea to the policymakers and also to quality management directorate. And thereafter, we trickled down to the facilities. The other thing about this intervention is that we were very inclusive in both public and that had 1,500 deliveries in a year. They were included within the trial, so it means that actually not only the public benefited, but also the Christian-based facilities as well as the other private facilities. This was a way making sure that we're not leaving any women behind if they go to the public or the private. We were also strategic within our champions in that our healthcare workers, we knew that for us to achieve the three goals, we need to make sure that we've got the nurse, the clinician, the hospital attendant, as well as someone from pharmacy to help us with the supplies. And at the end of the intervention, we converted all the control sites with the APT-Sepsis program. So meaning to say, for Malawi, it meant that all the districts actually, they were converted now to adopt the program. And during the process, we found out that actually students were also part of the team. So we went over to engage the training institutions to make sure that also they adopt the APT-Sepsis program within their curriculum. And this is an ongoing process happening. In Malawi, the big three causes of why mothers are dying is sepsis, postpartum hemorrhage, as well as hypertensive disorders, preeclampsia, eclampsia. So whenever we are doing our supervisory visits within ministry, we have made sure that we integrate the sepsis bundle within, in as much as we've also integrated the PPH bundle through emotive. And also we've also prepared something in terms of the warning signs from hypertensive disorders in pregnancy. So any supervisory visits, it means that actually all the three big killers are being tackled and making sure that the facilities are getting that on board. There's an issue of sustainability, which is what we're working on now, looking for partners coming on board to make sure that we still push the same agenda and we still reduce the numbers of maternal morbidity and mortality due to sepsis. And just to wrap it up, really, I believe we could not have been here without acknowledging the champions, the project officers, and the women that managed to tell the story, but also that contributed to the data set we have. And of course, the sponsors as well as the whole trial team that we have on board. So thank you very much, Mercedes. Over to you.
Thanks, Louis. So we will start closing this webinar. Not without saying that results of the APT-Sepsis trial are actually very encouraging. We are really pleased that you share our urgency for strengthening infection prevention and control measures, supporting antibiotics stewardship, and prompt identification and treatment of maternal infections. From the beginning, this program and the trial were conceived and implemented in a very collaborative way as a shared responsibility for everyone, researchers, policymakers, health workers, communities, and our partners. I would like to start thanking all our speakers today for their presentations and for sharing their insights. Thanks to the study teams in Malawi and Uganda, the facility champions and staff, the members of the public patient group, members of the independent data monitoring committee, and the trial steering committee. Special thanks for the ministries of health in Malawi and Uganda, as well as for the funders of this study, MRC, the NIHR, the UK Foreign Commonwealth and Development Office, and HRP. Thanks to WHO, HRP, and Liverpool for coming together and contributing to the organization of this webinar. Of course, many thanks for you for participating. WHO remains committed to strongly support country and stakeholders' improvement and efforts in the area of maternal infections and sepsis. As you heard, more results will be available in 2026 based on the mixed methods process evaluation and also the cost evaluation that was implemented along the APT-Sepsis trial. This tool will give us more insights on how best we can improve care to prevent and treat maternal infections and sepsis. We really hope that our efforts to develop and test this program will in the future help health workers better implement what we know works, and that we will see more women benefit from high quality care in health facilities. We also look forward working together with you to achieve this. Many thanks for attending this webinar.